Hi, I'm Mike Gilliam, and welcome to Talking Health. Over the last few years, much of the conversation related to health care across the country has focused on the Affordable Care Act, or so-called Obamacare. After a very difficult rollout of the healthcare.gov website October 1st of last year, the exchanges and plans are now up and running. But there's still a lot of confusion about what's available, who is eligible for which plans, and what the various plans will cost. Today, we'll walk through the process and the various plans with a navigator who's charged with guiding people through the paperwork and options available and enrolling them through New York State of Health, the state's exchange. We'll also talk to an insurer who runs one of the largest plans in New York State. Joining us now is Metroplus Health Plan President and CEO, Dr. Arnold Saperstein, and John Cuda, their Chief Financial Officer. Dr. Saperstein, lots of problems with the rollout. From your vantage point, where do we stand now?
I think as time goes on, things have gotten much, much better, and actually the rollout for New York State was much smoother than for many of the other exchanges. I think the New York State website had some difficulties in the initial days, but over time, individuals had a much easier time to sign up. And from our plan alone, we have almost 30,000 people that have applied for coverage through us over the last couple of months. And I think a number of things that have happened that the state had done is extend the time for individuals to be able to apply for their care. Initially, the deadline had been for January, for example, on December 15th, and that was extended to December 23rd. And also because it was a new program, initially the individuals would have had to pay by January 10th. We're now given an extension. They allowed the plans to extend the time for individuals to pay till the end of January. So the state has made certain flexibility in their website and timeframes, and the plan has also made some changes to allow individuals to have a smoother opportunity to sign up for health care.
John, from the financial end, that's worked out very well.
I think so. We targeted a lower cost program. We really were targeting to come in at a second lowest silver, which the advanced payment tax credit was pegged to. We actually wound up in 3 of the programs coming in at the lowest plan for cost at about $360 for a silver product. And that actually, I think, allowed folks to really look at Metroplus and say, I think that a plan with their history, the quality, and that low cost allowed them to choose us and let us grow and hit those types of numbers. And I think that really smoothed out our launch so that we actually have a good mass of members that helps us to manage a population. A small group wouldn't be as easily managed as a population that we could hit 20 or 30,000 members.
When you talk about these members, the people who've been signing up, how many of them are people who were unable to get insurance before, who are getting insurance for the first time through the Affordable Care Act?
I think many of the individuals who actually signed up for us are individuals who were dropped from their small business and individual coverage that they had with other plans. And there were also individuals who had not had insurance before. Another interesting thing that we've done is we've noticed in the health exchange, the essential benefits only has, for instance, dental care for pediatrics. And one of the things we did when we put in our plans is we created a non-standard plan which has vision and dental coverage. And
included in the plan?
That if for a slightly increased cost above the base cost for the gold, silver, platinum, and bronze products, if they paid us a few dollars more, they were able to get vision and dental coverage. 80% of the people who signed up for us actually chose our non-standard program to be able to have the vision and dental coverage.
So do you think that that was the draw, that dental plan and the vision coverage?
I think from our perspective, the couple draws were a very cost-effective plan. We're at this point the lowest cost plan, as John said, in 3 out of the 4 programs, as well as individuals who wanted to have vision and dental at a relatively very low cost.
And a lot of that was actually done through something called navigators. We spent some time with a navigator here in Manhattan just recently.
I think you had a doctor.
Yes. Mm-hmm.
But the doctor doesn't accept.
No, he said that he told me he don't.
Drew Rabidoux was part of a group trained by New York State this fall as navigators. She works out of the Community Service Society in Manhattan.
One of the great things about going to a navigator is we can sort of walk somebody through. How much do you use the doctor? Are you going to go to the specialist a lot? So does it make sense to pay more per month but have less of a deductible? Or talking to somebody about their particular situation, are you going to be able to afford $3,000 upfront for a deductible if you have a bronze plan, for example. So, you know, what is realistic for you? What are you able to pay? And we just educate people about their different options.
Under the Affordable Care Act, the plans are set up and listed as separate metal tiers.
There's bronze, silver, gold, and platinum. Now, the bronze is the lowest cost, but it has a $3,000 deductible and a maximum out-of-pocket of $6,350. So it's a lower cost, but your deductible is higher. Next, we go up to silver. Silver is a $2,000 deductible with a maximum out-of-pocket of $5,500. So it costs a little more than the bronze, but a lower deductible. Then you go to gold, which is a $650 deductible and a $4,000 max out-of-pocket. So it's a little bit more expensive than the silver, but smaller deductible. And the highest is platinum, which is no deductible and a maximum out-of-pocket of $2,000, but is the most expensive. Now with the tax credits, you can apply the tax credits to any of those metal tiers. But for people that are between 138% of the federal poverty level and 250% of the federal poverty level, qualify for an additional assistance with a silver level plan only. And that's called the cost sharing reduction. And that will bring their deductible down based on their income and also their maximum out of pocket. So for people between 138 to 150% of the federal poverty level, they can get a silver plan with a $0 deductible. So they're basically getting a platinum level plan for a silver level price and lowered with their tax credits. So it depends on your income. It depends on your medical needs, which metal tier and which plan is the best.
Fernando has 3 sons and makes about $40,000 a year. Drew walks him through the enrollment, entering all of his vital information into a secure website. None of his information is stored on site on the computer she uses for security reasons. Right off the top, Fernando's family benefits from the ACA because his sons can stay on his plan until they're 26 years old. But Dad needs a plan. They find a plan that costs about $300 a month, but Fernando balks.
I go for the doctor 2 times in the year. I spend $300 per year. Now when I need to pay for insurance, $300 a month. Again.
It would be more affordable if Fernando was eligible for tax credits, but he wasn't because he separated from his wife and filing separate tax returns. Since Fernando attempted to enroll, the state has recognized the problem.
There's been a recent development in New York State. If you have a legal separation, you can both get tax credits.
Talk to me about what difference that makes financially for Fernando.
For Fernando, it makes a big difference because if he files taxes with his wife, they'll both get a plan for $47 a month.
Instead of $307?
Yes.
That's great.
Yes, that's great. You would never have found that before, even with a subsidized plan.
How often is it happening where people come in and say, hey, you know, I'm going to have to find a new doctor because my doctor says he's just not going to accept this?
Sometimes people think at first that they're going to have to do that. For example, I had a client that was in the same situation. She thought none of her doctors accepted the plans. But after further investigation, the doctor either changed their mind and signed up for the plan, or she found that they actually did take it, but they didn't realize that they took it. So that sometimes happens too.
Okay, so this is a lot of education, actually, even for the doctors as well, then.
Yes.
Talk to me about the woman who had to actually go to France before, but now she's able to find insurance.
We see quite a few people like that live in fear that they're going to be sick, that they're going to need to go to the hospital, that they're going to incur a $60,000 bill. They couldn't afford insurance before because it was $1,000 a person in New York City. Like this woman from France, she couldn't afford that.
She's a citizen?
And she's a permanent resident, yes.
So in other words, she was getting her medical care out of country?
Yes, because she couldn't afford it here. She would get her checkups there. She would get her dental work there. She would get everything over in France because she couldn't afford it here and she didn't have insurance.
And now?
Now she has a $60 a month plan, and she added a dental plan to that. So she's not only going to get the medical care that she needs and not go to France to get it, but she's also going to get dental care. It's like she won the lottery because she's able to finally not worry about getting sick and not planning her trips to France around when she would get sick.
Now, Dr. Saperstein, you guys handle that a little bit differently. Talk to me about that.
Well, we have certified application counselors. Navigators are funded by New York State and actually can help an individual to learn about what the exchanges offer and the different health plans and the different coverage and help an individual sign up. We have certified application counselors that can do the exact same thing as the navigators, except that they're not funded by the state, they're actually funded by our plan. They go through a training that's almost exactly the same as the navigators. So our employees, we train the trainers to learn how to become a navigator certified application counselor, got certified to do the training, and then have trained our enrollment staff to become certified application counselors, because almost all of the enrollment that's happening in New York State, both from the Affordable Care Act, Medicaid, Child Health Plus, all of the programs are shifting to using the New York State State of Health website. So you have to be certified as either a navigator or a certified application counselor to provide that assistance. So it's really just a different name and a different funding stream, but they can do the same things that a navigator can do.
And a very important position.
I think very important, because even though the website's working well, the information is very complicated, and many, many people would like assistance in understanding it and helping them navigate through the website, and that's what our employees are available to do.
What's that going to cost me to go to that navigator? And we need to explain that to the viewer, as how that actually works.
There is absolutely no out-of-pocket cost for any individual to sit with a navigator or with a certified application counselor. They are there to help individuals navigate through the website, navigate through the system, and enroll in healthcare. They do not have to pay anything to those individuals.
You guys are a little bit different than, say, Aetna or something like that, because you're running a hospital. Do you think that has played into your success as far as enrollment's concerned?
Well, we're part of the New York City Health and Hospital Corporation, which is the largest public hospital system in the country. But we have all of the Health and Hospital Corporation hospitals and doctors, but we have an additional 14,000 community providers and sites and other hospitals outside of HHC to have a broader network available to our membership. So our patients can get care at the Health and Hospital Corporation facilities. We expect them to be admitted there, get specialty care there, but there's certainly a very broad network of community doctors, especially primary care doctors, that are available for individuals to go see their doctor in the community, and then if they need to be admitted, they can get admitted to one of our hospitals for additional care.
But so having that set up, do you think that has added to your success, has helped to draw people to you?
Well, I think the New York City Health and Hospital Corporation is a very high quality performing group of providers and hospitals. And Metroplus has been rated, there's a consumer guide that New York State puts out. So the New York State Consumer Guide for New York City plans, which is based on quality and overall satisfaction, rated Metroplus the #1 plan for 8 out of the last 9 years. And I think a lot of that high quality measurement is based on who our providers are. So they've certainly helped us become such a high quality plan, as well as our other providers, but I think HHC has been had a major impact on our quality results. And when individuals look at how we perform, not only are we low cost, we're also very high quality and high performing. So I think that's certainly been a draw also for individuals.
I just think that being provider owned, I think, has led to that success, because most of us come from the provider side, and that we take the provider viewpoint. So we understand what the providers go through. We know how difficult it is for them to provide care, and how important it is to be reimbursed for that care. And we really focus, our function is to provide the necessary care and to pay for it. So we do things like we pay in under 10 days, our average payment lag for bills. So, and that's because we're part of that provider organization, and that's what our role is. Our role is to support the provider organizations, not only our parent, but anyone who contracts with us.
Now, not all hospitals feel that way. There are some who are not taking part in the Affordable Care Act. What do you think about that?
I think a number of hospitals expected that this program will be a pure commercial program which would draw very high reimbursement and high rates. Yet in order to be cost competitive and cost efficient, the plans have to negotiate with the hospitals to some reasonable rate of reimbursement. Those hospitals that expected the very high rates were not interested in the rates being offered, certainly by us and by many other plans in addition, because some hospitals had actually shied away from signing contracts for the exchange products. Many hospitals have signed up and are positive, and we've actually had a number of those other hospitals come and approach us with interest now to sign up for the exchanges now that the program has started and they see that we have 30,000 applicants, so we have significant volume, and the hospitals want to do business with us. So many of them have actually approached us again and said, we want to take another look and we're interested in joining your network.
Interesting. So what they're basically saying is they realize it's volume driven, right?
Correct.
It doesn't make good business sense not to have you.
Well, individuals, again, as a health plan, we would hope that our members receive their elective care. Emergencies, we understand if somebody ends up somewhere in an emergency, we're okay with that. But care that's planned and care that's, the routine care that's delivered to individuals, we would want that they would occur at our network facilities and our network hospitals. So those hospitals don't want to be, especially now that we have the volume, don't want to be left out of the potential of this, large group of members to go to who might need to go to the facilities or might want to go to their facilities.
When people argue against the Affordable Care Act, one of the big concerns that they always point out is the young people that are needed to make this whole thing work, the so-called invincibles, and the fact that, well, we don't believe they're going to spend money and sign up. What have you found?
We've actually had a very different experience. What we've looked at, I think 43% of our population is under age 35, which is a very significant surprise. And then when we looked at all of our age groups, 70% of our population that applied for Metroplus are under the age of 50. So we have not had the experience of having an older population that has more chronic illnesses and greater health needs. We've actually had a relatively young population sign up for us.
John, what's the draw there? Is that cost factor again?
I think so. Having that lower cost allows folks at that younger age group who are the invincibles, who don't really think they're going to get sick or have limited health care needs, they're able to sit back and say, I can look at a Metroplus health plan with the slightly smaller network and the significantly lower cost, and it's not that much money out of my pocket that I would have to pay in order to get health care coverage. One of the things on the cost side was that even though we can't do the math in our heads on the APTC calculation, but the way it works out is somebody at very lower income, say an income of around 150% of poverty or lower, really only has out of pocket about a 6% cost for their health care. So the tax credits and the cost share reductions really make it affordable for people to access the care. And I think for our plan, we've seen the young people have made that decision and joined our plan.
Okay, so Metroplus, who is eligible for Metroplus?
Okay, so in addition to the members we've been talking about in the Affordable Care Act, the exchange membership, we have a number of other programs. We have Medicaid programs. We have a Family Health Plus program, which is for adults over the income level of Medicaid. We have a Child Health Plus program. We have 2 special needs programs for members with HIV, both a Medicaid program and a Medicare program, special needs for HIV. We have a managed long-term care program. We can enroll individuals that are employees of the New York City Health and Hospital Corporation. And we have a number of other Medicare programs, both for individuals with straight Medicare and for dual eligible members with both Medicare and Medicaid. And we have a managed long-term care program for individuals that need home care in order to be able to live comfortably at home without having to go to a nursing home if at all possible.
And geographically, who can?
We're licensed in 4 counties of New York City. We have Manhattan, the Bronx, Brooklyn, and Queens. And we have about over 430,000 members in just those 4 counties of New York City. And interestingly, you say we're a relatively small geographic area. When the state has released data on the Affordable Care Act and the exchanges, the last press release that they had about how much plans got, they had that Metroplus had 11% of the entire statewide applications, even though we were located in just 4 counties of New York City.
That's good. Yeah. What about small businesses? How have they been affected by the Affordable Care Act?
I think we actually did start a small business program, a SHOP program under the ACA. And to date, we've had about 132 businesses that have signed up with us with about 380,000 members. We're in the process of reaching out to those companies to get a feel for who they are. This is brand new business for us. It's a new entrance for us into this small business market. We came in again as the low-cost option under the SHOP program.
That number, is that a good number? Can you put that into perspective?
To start, yes, I think that's a good start. It's brand new for us, so we're learning how to deal with this population. We're learning how to deal with this industry in the exchange, and it's all new to everyone. And I think to start a little small, and we've seen some growth. We started January with a smaller number. The numbers I gave you were through February and a little bit of March. And I think as the open enrollment winds down towards the mid of March, we will see some additional growth, and I think it'll be a population that'll be sizable enough that we can manage, and it'll be sizable enough so that we can spread the risk for those lives over our business.
What do you guys expect next year?
Well, next year we know that some of the costs have to rise. There's inflation in medical cost. We're looking to expand the network, and that means contracting with hospitals that are looking for higher reimbursements that we currently pay. So we know that the costs will have to come up. At least
You're talking about the premiums.
The premium cost would have to come up some percentage points just to meet regular healthcare trend and some of our widening of our network and maybe expanding some of our benefits, similar to what Dr. Saperstein was saying about the dental and the vision. We charged a very small premium, about $22 extra per member per month to have that type of coverage, but we made it a very narrow and a very limited type benefit. You can get the benefits you need, but it's not everything you may want, because we were trying to appeal for the need, not the want of what the people were looking for.
So you might come up with something like a tier for the dental and vision as well, so that you could buy maybe that very low entry fee priced program now, but maybe next year there might be something, the Cadillac of the dental program that would be available.
Greater selection of frames or something.
Maybe
like
not a Cadillac.
Right now we have availability for instance, in the vision benefit, for the optometric evaluation for glasses or contacts, and then also it supplies one pair of glasses, but the frame list is maybe more limited, and we want to be able to expand flexibility for individuals to have greater flexibility in choosing what they might want in the vision care.
Yeah, I think when
right now, all of the core of vision and the core of dental is definitely covered.
I think that when we designed this because we knew that the family health population was moving out of that product. It's being phased out, and some of those folks will be phased into Medicaid. Anyone who's under 138 of federal poverty level will go into the Medicaid program, and the folks that are between 138 and 150 will go into the QHP product, into the exchange product. We designed our product to capture that group because we are a government type program, and coming into the commercial product was a new entrance for us, and it's a new population. So we designed it mostly around the population that we knew and that we wanted to capture and retain. With some experience and seeing that we've actually opened ourselves up to a new population, folks that we didn't have before, true commercial members. We're going to take a look at our benefits, and we're going to take a look at our product designs and maybe tailor them a little so that it's more appealing to those people as well.
So John, do you think you guys will turn a profit on this, or how does that look?
I think the way we built the product actuarially, we did build a profit into our assumptions as we created our bid. Our assumptions seem to be sound. We are meeting most of the guidelines that we laid out for a product. We're getting that lower age membership. We'll get the health assessments in. We'll find out what the folks need. We will try to hit, or we will hit the minimum of 80% of a medical loss ratio. So there are criteria that the program, you need to spend the premium that you collect on the health care costs of your membership. So if all of that works out, I think we could hit those profit margins, and we could hit the numbers that we projected into our bid. So I think all in all, we should be okay. I think I'm not too worried about it financially. And from our history, Metroplus has always made everything that we've gone into work. And as Dr. Saperstein alluded to, doing it at a high quality and a high level of satisfaction, I think we'll do the same for any product that we offer.
Dr. Saperstein, the Affordable Care Act, good policy or not?
I think overall, very, very positive. Gives individuals who did not have insurance before an opportunity to buy insurance at a lower cost than they could have before. It also allows plans to expand their potential membership. The plans like ours that had government programs to actually expand it to individuals in a commercial population to buy our insurance. And our hope is that we'll be able to provide the highest quality of care and have a satisfied customer base. I'll certainly know more after a year. Things were a little, there was some anxiety at the beginning with the website and with sign up, but I think as time goes on, we're working with our membership, we're working with our providers, and we hope to provide a very good product to them. And I hope next year when you ask me, I'll be able to tell you everything went great and we have a very satisfied and healthy customer base.
We'll have you come back.
Thanks.
Okay. So after a rocky start, the Affordable Care Act is reality. Open enrollment for 2014 ends March 31st, and if people haven't enrolled in a plan by then, they generally can't get 2014 coverage until the next open season, which starts on November 15th. If you don't have coverage, you may have to pay a penalty. I want to thank our guests, Metroplus Health Plan CEO Dr. Arnold Saperstein and CFO John Cuda, for joining us. And we'll see you next time on Talking Health.
This broadcast has been brought to you through a grant from the Commonwealth Fund.